Okay, so next we're going to talk about some wound complications. First, we'll talk about dehiscence and evisceration. Dehiscence is when the edges of a wound separate. So that can happen really on any wound. Say I have an incision here, those edges can separate. When we talk about evisceration, though, that's when we have wound dehiscence and internal organs protrude, and that's almost always going to be referring to an abdominal wound. So dehiscence is not necessarily an emergency if it is a partial dehiscence or it's not over critical structures. So if I have a wound here and it dehisces, then I'm probably just going to have a bigger scar, right? Needs to be addressed. If I have an abdominal wound that dehisces, I'm going to need to assess, is that a complete or partial dehiscence? Evisceration is always an emergency. So emergency management for a complete dehiscence or an evisceration, you remain with the client. That client is likely to experience shock, so likely to go into shock. You call for assistance. You have someone bring you some sterile gauze and sterile saline, and you want to soak the gauze with a saline and cover any protruding organs. You want to position the client supine with their knees bent and their head slightly elevated so you reduce the stress on that wound. Monitor their vital signs and observe for signs of shock. And that patient needs to be NPO because you're going to be preparing them for emergent surgery. Okay, so this is about minimizing damage. We want to minimize the risk of infection by covering that wound, keep those organs moist so they don't start to dry out and get damaged. Monitor for shock and be prepared to manage that. So this patient is going to need some large bore IVs. They're going to probably need additional IV fluids. Whatever's needed to get them to surgery is happening. Big thing is you never leave that client. You stay in the room and call for help from there. So another potential wound complication is hemorrhage. And we might see a sudden increase in external bleeding with a hemorrhage, but we might not. So internal hemorrhage, what would that look like? The area might become swollen or distended, or if they're bleeding into a large body cavity, they may have or a large muscle, they may have a lot of room to lose blood before it's noticeable by any external assessment. So we might also see some changes in their vital signs. This is really, really important. When a patient is losing blood volume, they've lost too much fluid, they're too vasodilated, anytime a person is going into shock, their heart rate will increase unless a low heart rate's the cause of that shock. Don't get me with cardiogenic. I hear my paramedic at Idabel tell me about that. But if we're having shock because of hypovolemia or vasodilation, we're going to have increased heart rate before the blood pressure drops. So if you're monitoring your patient's post-op vitals and their heart rate is gradually increasing, don't assume everything's fine because their blood pressure is okay. They can lose a lot of blood into the abdominal cavity before we notice it, before we can palpate it or see it. So pay attention also to your patient's vital signs. We may also see a large hematoma develop if someone, say, one example of that is someone's had some sort of arteriography. They've had either a heart cath or they've done a cerebral angiogram. So if they've entered a large artery to be able to inject dye and look at things, okay, whatever they're looking at, they've entered a large artery, one of the risks is hemorrhage. So we might see the blood coming out, but we might also see a large hematoma develop. So we're going to look for swelling, distension, hematoma, sudden increase in external bleeding, or signs of shock. We have a patient that doesn't look right, get a set of vitals and see what's going on. Emergency management for a large hemorrhage, stay with the patient, try to help the patient remain calm, call for assistance, apply a pressure dressing if the bleeding is coming from a place that you can apply pressure to. Monitor their vital signs, observe for signs of shock, and again, they're going to be NPO, getting ready to go to surgery, large bore IVs. They're probably going to need some IV some IV fluid replacement, possibly blood replacement, depending on the amount of blood loss. Infection is another wound complication. We're going to observe for a purulent drainage from the wound. We're going to observe for the odor from the wound, pain that's increasing when it should be decreasing. This is a major sign of infection. We expect wounds, post-op, we say about day 3 is usually worst. We expect wounds to get a little more painful in the initial days, and then they should start getting better. There are surgeries that are very painful. So if the patient says expect a lot of pain for the first 2 weeks, we expect a lot of pain for the first 2 weeks. But if we expect a lot of pain for the first 3 days and then expect it to be getting better, if the pain is coming back or it's getting worse or it's worse than anticipated for that particular surgery, always assess for infection. We might also see redness, swelling. If it's internal, we might not see those things. We might see increased temperature, pulse and respiratory rate, increased white count. Okay. Management, we want to prevent infection. Good nutrition, good rest, good hygiene, good wound care, good patient teaching. If we have a patient who has signs of infection, we notify the provider. When you're doing a culture and sensitivity, do you want to culture the purulent drainage? You have a wound and there's pus in the bottom of it. You don't culture the pus. You want to clean out the pus, clean out the drainage, and culture the base of the wound. Pus is a common, it may have some live bacteria in it, but what it mostly contains is tissue fluid, debris, dead white cells, dead bacteria. So it might not actually grow out on culture. So clean the wound, culture the bed. Okay. And we administer antibiotics as they're ordered and appropriate for the patient. Okay, the next section we're going to talk about pressure ulcers, which is really specific type of wound.